Stage 3, those two words for many, they're the only thing that truly registers after breast cancer diagnosis. And honestly, they can hit like a life sentence. But here's the unexpected truth, the crucial twist. Not every stage 3 cancer story unfolds the same way. And conversely, plenty of stage 1 cancers still demand an aggressive, multi-pronged attack. So what do these numbers really signify? Why do they hold such immense power in shaping what happens next in your journey? I'm Dr. Alex Popovich, a breast surgeon right here in Wellington, New Zealand. Over the next several minutes, I'm going to unpeel the layers of breast cancer staging, walking you through exactly how we determine it, why your stage isn't some kind of moral grade, and how the very same number can translate into two profoundly different paths for two different women. Why does staging matters more than the name of cancer? With those shattering words, you have breast cancer. Your brain understandably screams for one single undeniable fact. How bad is this really? Staging is our universal scientific answer to that desperate question. It is the language that transcends borders, allowing doctors anywhere in the world to open your chart, see something T2N1M0, and instantly precisely picture the cancer's entire geography. They can see where it started, which train lines it might have traveled along, and crucially, whether it's already bought a ticket for a much longer journey out of town. It decides whether you'll meet the surgeon first, ready to intervene, or if the chemotherapy specialist will be your initial guide, shrinking the enemy before any cutting begins. With it, we can tailor treatment so incredibly precisely that two women, both of whom might tell their friends they have stage 3 breast cancer, could end up receiving opposite therapies, each perfectly situated to their unique situation. I have talked a bit more about the stage versus grade in the previous video, so I'll put the link down below where you can watch it. But think of it this way. Stage is all about geography, where the cancer is located, how big it is, and how far it's spread. Grade, on the other hand, is about personality. It tells us in a very specific medical sense how angry or aggressive the cells appear when a pathologist meticulously examines them under the microscope. A high-grade aggressive tumor can still be classified as stage 1 if it's a tiny 8mm speck sitting quietly and contained within a breast tissue, having not ventured out. Conversely, a low-grade tumor, meaning its cells appear quite polite and well-behaved, can be classified as stage 3 if it has crept stealthily into 10 or more lymph nodes, indicating a significant regional spread. See the difference? The cellular behavior grade is distinct from its physical location and extent, which is stage. Hold on to that distinction. It's a game changer, and it will save you lots of unnecessary midnight Googling and anxiety. Understanding this nuance is key to truly grasping your diagnosis. The TNM is the alphabet you can actually remember. So let's decode the secret language we as doctors use to stage breast cancer, or actually majority of cancers. And it's not nearly as complicated as it sounds because we use 3 familiar letters you already know, T, N, and M. Each letter corresponds to a crucial piece of puzzle, and each gets a number attached to it, like detailed coordinates on a map. T stands for a tumor. This tells us about the primary tumor itself. We measure its size in centimeters, and we also note whether it has become stuck or attached to the skin of the overlying breast, or more seriously, if it's gotten attached to the chest wall underneath. TIS, or tumor in situ, means it's right where it started with zero spread beyond its original duct. T1 indicates a small tumor up to 2 centimeters in size. Think of it as a small pebble or a grape. T2 means it's a bit larger, between 2 and 5 centimeters. It's more like a golf ball. T3 is a tumor's larger than 5 centimeters. Now we're talking about something the size of lemon or cricket ball. T4 is any size, but it's now attached to the chest wall or the skin, or causes ulceration of the skin, or there is something that we call inflammatory breast tumor. Now, N stands for the nodes. These are your lymph nodes, those little organs that are strategically placed throughout your body, particularly under your armpit, which are the axillary lymph nodes, above your collarbone, which are supraclavicular lymph nodes, or behind your breastbone, which is internal mammary node. They're part of your immune system, and they trap cancer cells that have escaped. N0 means no lymph nodes are involved. They're all clear. N1 means cancer has spread to 1 to 3 lymph nodes under the arm. N2 signifies 4 to 9 lymph nodes involved, or if the lymph nodes are bulky and stuck together. N3 is the most extensive nodal involvement, meaning either 10 plus lymph nodes, or the lymph nodes are found under breastbone or those above the collarbone on the same side as a cancer. M stands for metastasis. This is a big one. It answers a critical question whether the cancer has spread into a new distant camp like liver, lungs, bones, or brain. M0 means there is no distant spread as far as our current diagnostic tools can tell. M1 means we have definitely found cancer cells somewhere else in the body. When we slide these 3 letters and their corresponding numbers together, it gives us the definitive stage from 0 to 4. And it is done after the surgery. That's the only time we can get a comprehensive picture. Stage 0. This is what we call ductal carcinoma in situ. Think of it like this. The cancer cells are locked securely inside the milk duct, like prisoners behind the bars. They haven't breached the duct wall known as the basement membrane. This literally means they cannot march to reach the adjacent breast tissue, and they can absolutely not reach the lymph nodes or cause distant metastases. It's the cancer at its earliest, most contained, and most cooperative. Because these cells are so perfectly contained, the treatment is usually incredibly effective. Often it involves lumpectomy if it's small enough, which is removing just the affected area, possibly followed by radiation therapy to minimize the risk of it ever coming back. But sometimes the area of DCIS is quite large that mastectomy has to be recommended to ensure that everything is removed. The prognosis here is outstanding. The 10-year survival rate exceeds 98%. Stage 1, small but not to be ignored. Stage 1 is considered early stage breast cancer, and while it's small, it certainly cannot be ignored. It splits into 2 categories, 1A and 1B. Stage 1A is more straightforward one. You have a small tumor up to 2 centimeters in size, that's T1, and absolutely no lymph node involvement, N0, and no distant spread, M0. That's T1, N0, M0. It's contained early stage breast cancer with excellent prognosis. Stage 1B is a little bit more nuanced, perhaps even a bit weirder to understand at first glance. Here, we might not even have an actual measurable tumor in the breast, or perhaps we have a small tumor in the breast, but what defines 1B is the presence of tiny clusters of cells, microscopic, in 1 to 3 lymph nodes. The key here is that even though the breast tumor might be elusive or small, the fact that cancer cells have reached the lymph nodes, even in microscopic quantities, means it's a slightly different beast than 1A. Despite these distinctions, both 1A and 1B are still very much considered early breast cancer. For most women diagnosed at this stage, if the cancer biology is favorable, meaning it's hormone receptor positive, HER2 negative, and low grade, you might be able to skip chemotherapy altogether. Instead, you'll likely head straight to hormone tablets like tamoxifen or aromatase inhibitor, and some radiotherapy. The cure rates for stage 1 breast cancer are incredibly high, sitting around 90 to 95%. The core message for stage 1 is this: small does not mean casual or easy. It means curable. It means we have caught it early enough to make a profound difference. Stage 2. This is a gray zone where a lot of women sit. It's characterized by either slightly larger tumors between 2 and 5 centimeters, meaning T2, or involvement of 1 to 3 positive lymph nodes, or sometimes combination of both. You'll quickly become familiar with the term multimodal therapy at every single appointment, because this stage almost always requires a combination of treatments working together like a concert. The approach here is highly individualized, tailored to your specific cancer's biology and your personal preferences. For instance, consider a 35-year-old woman with a triple negative aggressive 4 centimeter tumor. For her, would almost certainly recommend chemotherapy first, which is known as neoadjuvant chemotherapy. The goal is to shrink the tumor as much as possible before surgery, making the operation potentially less extensive, and also, more importantly, allowing us to assess how the cancer responds to treatment. After chemotherapy, she would typically have surgery, followed by either more chemotherapy or radiation. Now, if you have a 65-year-old woman with a 2.5 centimeter strongly hormone positive breast cancer, she may go straight to lumpectomy, have a sentinel node biopsy or axillary node dissection, and then begin hormone therapy and radiation, and potentially never need chemotherapy at all. This is where we often use something called oncotype testing or genetic type profile of the breast cancer itself to see whether women in this category belong to a group who has a high chance of recurrence versus lower chance of recurrence, and whether or not they might require chemotherapy. And this is where you see the same stage with vastly different journeys, and all because of the uniquely biological fingerprint of each cancer. This highlights why your specific pathology report is so much more than just a number. 5-year survival rates for stage 2 breast cancer average between 80 and 90%. But remember, individual biology can change that number significantly, either up or down by as much as 20%. It's a stage of careful consideration and personalized pathways. Stage 3, locally advanced, still aiming for cure. This is where cancer has really decided to spread significantly into neighboring lymph nodes. It means disease is locally advanced. We're talking about tumors larger than 5 centimeters or 4 or more lymph nodes involved, or perhaps the lymph nodes are so matted, which means that they're stuck together, or the tumor itself has started to invade the skin or underlying chest wall. It's more extensive regional spread, making it more complex challenge, but crucially still one where we are absolutely aiming for cure. Here in New Zealand, for many stage 3 cases, we routinely start with chemotherapy. We call this neoadjuvant therapy, meaning before surgery. The strategy is to hit the cancer hard up front, shrinking the tumor and ideally sterilizing those affected lymph nodes. This approach can be incredibly effective. If that large stubborn mass of cancer melts away completely, leaving no trace of cancer in the tissue removed during surgery, we call that complete pathological response. Believe me, that's a phrase that makes surgeons, oncologists, and patients alike want to go, yay! After the initial chemo, we proceed with surgery, then radiation, and finally add hormone or HER2 targeted therapy, depending on the specific status of your cancer. Stage 3 can indeed still be cured, but 10-year survival rate is lower than earlier stages, and it's anywhere between 50 and 70%. Stage 4, metastatic, manageable. This is a stage that strikes the most fear, often whispered with a sense of finality. It means cancer cells have broken free and established satellite offices in distant organs, perhaps the liver, lungs, bones, or brain. At this point, our primary goal shifts. We're no longer chasing a definitive complete cure in a traditional sense. Instead, we're managing a chronic disease, much like diabetes or heart disease, rather than a one-off event like appendicitis. The treatment landscape for stage 4 breast cancer has absolutely exploded with options in recent years. We now have incredibly targeted therapies, CDK4/6 inhibitors for hormone-positive disease that can significantly extend life, groundbreaking antibody drug conjugates like trastuzumab deruxtecan for HER2-positive cancers that act like smart bombs, and immunotherapy for triple-negative cases. We even have a highly precise stereotactic radiation that can zap a single brain metastasis with sub-millimeter accuracy. These advancements aren't just incremental, they're transformative. The median, the most common survival for stage 4 breast cancer, has more than doubled in just the last 10 years, moving from around 2 to 4+ years. And a growing subset of women are living 10 years or even more. Quality of life becomes paramount in our discussions. We constantly balance scan results and treatment side effects with your ability to travel, work, enjoy your hobbies, and most importantly, to enjoy life with our family. Stage 4 is about living well for as long as possible. Biology steals the show. This concept is so fundamental, it bears repeating and emphasizing. You can have a stage 2B triple negative tumor, which despite being only stage 2, can be incredibly aggressive and outrun a stage 3A slow-growing luminal A tumor, which may appear more advanced on paper, but behaves much more gently. Why does this happen? Because the detailed biological characteristic of your cancer cells often swing the prognosis and dictate treatment choices more profoundly than the raw stage number alone. We're talking about things like your receptor status, estrogen positive, progesterone positive, HER2 positive. These markers tell us what medications and targeted therapies will work best. And then there is a proliferation, Ki-67, which basically measures how quickly the cancer cells are dividing. Because it indicates rapid growth, it suggests a more aggressive tumor. It's these intricate details that explain why two women with seemingly identical TNM classification can end up receiving completely opposite treatments and indeed have completely opposite outcomes. The numbers of the stage only tell part of the story. That's why it's absolutely vital to always ask for your full pathology report, not just simplified stage number. Understand the nuances, they're your power. Staging isn't a snapshot frozen in time. It's dynamic, it can be constantly updated as your journey progresses. We often restage cancers, especially after significant interventions like neoadjuvant chemotherapy. What we still cannot stage, despite all of our advanced technology and meticulous staging systems, there are aspects of breast cancer, but any cancer, that we simply cannot fully stage, at least not with our current tools. We call them micrometastases, individual cancer cells or tiny clusters of cancer cells that might be hiding silently in places like your bones. These are too small to show up on even most sophisticated CT scan. They are truly invisible to our current imaging technology. So what does this mean? It means that even an M0 designation, meaning no distance spread detected, is never an absolute 100% guarantee that there isn't a single rogue cell lurking somewhere. And that inherent uncertainty, that invisible possibility, is precisely why we continue to follow you for several years after your initial diagnosis and treatment. It's our long-term commitment of keeping an eye, always hoping for the best, but always prepared to act if those invisible cells ever decide to make their presence known. How fast can the stage change? The speed at which cancer's stage can change is often surprising, and it's a question that frequently causes anxiety. I've personally seen a tumor jump from seemingly straightforward stage 1 to more complex stage 3 in mere 6 weeks between initial biopsy and the planned surgery. This wasn't because the cancer suddenly grew exponentially in size, but because a more detailed information after the surgery revealed previously undetected lymph node involvement, which then completely alters the initial staging picture. The map got updated and the route changed. The cancer hasn't suddenly gotten so much more aggressive in those 6 weeks. It's just we did not know 6 weeks prior that it has already spread to the lymph nodes. And conversely, I've also seen the incredible power of aggressive chemotherapy drop stage 3 locally advanced tumor to pathological complete response, meaning no viable cancer cells were found at surgery within 3 to 6 months. This is the best case scenario where intense treatment before surgery essentially eradicates the visible disease. These rapid shifts highlight the critical point that the speed of change depends far more on the underlying biology of the cancer than it does on the calendar. Some cancers are inherently fast moving. We're talking about grade 3 ER/PR positive HER2 negative cancer or grade 3 ER/PR negative HER2 positive breast cancer, while others are slower. So please don't panic if your stage shifts during your treatment journey. It's not necessarily a sign that things have gotten worse irreversibly. Instead, we just know more precise, up-to-date information on your unique cancer. The most important thing to do is simply to ask your medical team, what does this change in stage mean for my next steps? How does it alter our plan? Understanding the implications is far more empowering than succumbing to fear. Talking to your team. Navigating a cancer diagnosis involves a lot of information, and it's easy to feel completely overwhelmed. To help you stay grounded and make most of your precious appointment time, I've put together a list of crucial questions. These questions will help you clarify your situation and empower you to be an active participant in your care. Don't be afraid to ask us, what is my exact TNM today? Get the precise TNM numbers. It isn't just curiosity, it's your specific coordinates at the time you talk to that doctor. Knowing this helps you track changes and understand discussions. What is my receptor status and Ki-67? My last video will explain this, and I'll put a link down in the notes. These are the details of your personalized care. Will I need neoadjuvant or adjuvant therapy, and what is the difference? This question often clarifies what treatment will happen before surgery or after surgery. Understanding the timings help you prepare mentally and physically. Question number 4. If I were your sister, what treatment sequence would you choose and why? This is a deeply personal question designed to elicit an honest, empathetic perspective from your doctor. It can help you understand the nuances and trade-offs of different options from a trusted professional's viewpoint. And please write the answers down. Bring a notebook or use your phone, and even better, bring a trusted friend or family member to take notes for you. The shock of the diagnosis, the sheer volume of medical information can make memories incredibly porous. Having these answers in black and white will be an invaluable resource as you process everything and make informed decisions. Maori and Pacific outcomes. This is a critical conversation we need to have, one that goes beyond just the biology of cancer. In New Zealand, we face a stark and unacceptable disparity. Maori women are twice as likely to be diagnosed at stage 3 or 4 breast cancer compared to non-Maori women. This translates to a devastating 30% higher breast cancer mortality rate. While biology certainly plays a role, we do see a higher incidence of aggressive triple negative disease within Maori populations. It is far from the whole story. The truth is, systemic issues amplify this disparity. Barriers to accessing healthcare, lower rates of participation in screening programs, and a high prevalence of comorbidities, which is other chronic health conditions, all contribute significantly to later diagnosis and poorer outcomes. These are not just statistics. These are lives, families, and communities that are deeply affected. If you're Maori or Pacifica, please advocate for yourself and your whānau. We must actively work to dismantle these inequities, and seeking out support system designed to bridge these gaps is a powerful step. Let's be honest, staging often feels like standing on the edge of a cliff, breath-holding, doom-scrolling through endless statistics online, 3 a.m. spreadsheet of survival curves. These are all incredibly normal reactions. It is a profound emotional earthquake. Knowledge is not about ignoring the fear, but arming yourself against it. You gain a sense of control when you understand the landscape. And remember this, share your stage, share your numbers only with people who truly deserve to hear your story, who will meet you with empathy and support and not with pity and unsolicited advice. Your story is yours to control. Let's quickly recap stage 0, cancer cells locked inside a duct. Think of them as prisoners behind glass. The cure rate is exceptionally high. Stage 1, small tumor or minimal lymph node involvement. Still very early. Cure rates are excellent, typically 90 to 95%. Stage 2, a bit bigger or a few lymph nodes involved. This is a bustling middle ground. Cure rates are strong, around 80 to 90%. Stage 3, locally advanced, meaning larger tumors or more extensive nodal involvement. It's a tougher fight, but we are absolutely still aiming for a cure with 10-year survival rates 50 to 70%. Stage 4, metastatic disease, meaning the cancer has spread to distant organs. While not traditionally curable, it's increasingly manageable as a chronic disease. And remember this above all else. Your cancer geography, its stage, combined with its unique biology, creates your personalized roadmap. It's never just one number. Staging is not a verdict or final judgment or prophecy of doom. It's purely and simply a coordinate. It tells us precisely where we stand today and this very moment, so that together we can plot the most effective, most personalized route forward. Fear is powerful, often debilitating emotion, but it doesn't need to define your journey. And most importantly, hold tight to the people who genuinely remind you who you are beyond any diagnosis and beyond any number. If you found this helpful, please consider subscribing for more straight talk videos like this. share it with someone who might need it, and drop your questions below. I truly do read every single one. In my next video, I will be talking about localization techniques for breast conserving surgery. Bye for now.